Satish bhai, you are in New Delhi somewhere?
Sir, I'm at Noida.
You are in Noida, yeah. I can see at the back that that's not your home.
It's a hotel room.
Yeah, that's right.
Yes.
Noida. Conference.
For a second, it's going online and then we'll start. So, good morning, friends. We start the meeting. Can you hear me well?
Yes.
Yes.
Okay. So it's a pleasure to introduce Dr. Urvinder Kaur, today's speaker. Actually, she is very familiar with Saturday Club of Baroda. She has been giving innumerable number of talks so far when we are meeting physically. I think online meetings is attending for the first time. So welcome, Dr. Urvinder. Thank you for accepting our invitation at a very short notice. As always, you are always ready with something to offer. And to introduce her formally, she is a consultant pediatric hemato-oncologist practicing in Baroda for more than a decade now. She had her BCH and DNB from Indore, and she had her hemato-onco training at the very well-known Tata Memorial Hospital, Mumbai. And she is practicing as consultant at KGP Children Hospital for more than 11 years. She is also a DNB teacher and guide, and member KGPCH research team and co-editor of Bulletin of KGPCH. Apart from this formal introduction, I must say that she is a very popular consultant hematologist in Baroda, and not only Baroda, across the state of Gujarat, because she is very cooperative. Personal level, I have seen that whenever we refer any patient to her, she is very meticulous in giving a feedback. She would enumerate everything that she has observed, and only hematology, she would chip in with some other things also if we have missed that in a particular case. So thank you very much, Dr. Urvinder, for joining the Saturday Club today. She is going to talk about thalassemia, newer therapies in the management of thalassemia. So we are all looking forward to your talk on what is happening in the field of management of thalassemia. And I will be leaving after a while because I am at some place where I cannot continue with this meeting. So I request Dr. Urvinder only to handle the question answer session later on, and you can end the meeting at around 9 o'clock. So please go ahead with your session, Dr. Urvinder.
Thank you, sir. Good morning, everyone. And thank you so much for the opportunity and so kind introduction. Today, we will be talking about thalassemia. It is a century-old disease almost now. And we really want to see where we stand today. Can you see the screen? Is everyone able to see the screen? Yeah.
Yes, we are able to see it. Please go ahead.
See, whenever I joined pediatrics almost 15 years back, the only thing I know about thalassemia at that time was a thalassemia patient has come for BT. And that has been happening for almost now 30, 40, 50 years. Thal for BT was a routine diagnosis on our discharge files. New thalassemia wards came up, and so much we have been doing regarding the complications relating to blood transfusion. But per se, anything to do with the disease has not been done much till recently. In the last almost 5 years, I can hear my echo of the voice. Yeah, that is fine now. No, I can still hear my own echo. Somebody's mic is on, if they can switch it off. Yeah. So, in the whatever is happening now has been because of the advances in so much of molecular genetics and understanding the biochemical processes. So let us start from a very beginning scratch, what is happening in thalassemia, what goes wrong, and where do we stand today. First, we need to understand the burden of the disease.
Urvinder, probably you've been muted accidentally, so please unmute, Dr. Urvinder. Dr. Urvinder, please unmute. You've been accidentally muted.
Yeah, that is fine. Can you hear me now?
Sorry. Yes, please go ahead.
Okay. So talking about the burden of the disease the world is facing about thalassemia, we will be amazed to know that around 1.5% of the world population is a beta thalassemia carrier. They are naturally selected because of their better ability to face the diseases like malarias. And because of this much amount of carrier proportion, around 70,000 newborns are born every year with the disease. And most of them are found in this geographic belt. And you can see India is almost entirely covered in this geographic belt. So in India, we are able to see thalassemia patient in every place, every state, every city. So what happens in thalassemia? First, we go back to our basics so that we understand the newer therapies better, which are targeted therapies. So unless or until we revise these concepts, we won't be able to understand what I'm talking about. So we all know that red blood cell contains hemoglobin, and a heme is there to take part of with the iron. And along with that, there are 4 globin chains, 2 beta chains and 2 alpha chains. The alpha chains are on chromosome 16, while the beta chains are on the chromosome 11. This is how an adult hemoglobin looks like. When the child is in the embryonic phase or during the fetal life, the hemoglobin starts, the erythropoiesis starts taking place at the level of yolk sac, and slowly it progresses from liver, spleen, and to the site of production becomes the bone marrow. And you can see the chains also differ. The beta chains comes very late in the life, almost at the time of birth, and actually picking up at around 6 months of age. And before that, there are various chains. But we need to understand that alpha chains has to be there if we have to survive this pregnancy. That is how alpha thalassemia, if alpha chains are not there, they present during the intraembryonic period only. Depending upon which other subunit is attached with the alpha chain, we get either embryonic hemoglobin, fetal hemoglobin, or adult hemoglobin. We need to understand that during the whole pregnancy, it is the fetal hemoglobin, and this switch takes over somewhere between 3 to 6 months. That is the actual age of presentation of thalassemia, where the switch does not take place, and the HbA, that is the beta unit, starts forming and remains there for the whole life. So what goes wrong in thalassemia? We understand that something is wrong with the globin gene, and whenever there is something is wrong in globin gene, we label it as hemoglobinopathy. Now this hemoglobinopathy is divided into 2 categories: quantitative defects or qualitative defects. When we have a point mutation in the globin gene, we call it a quantitative defect, and we get diseases like sickle cell, HBC, or HBE disease. While beta thalassemias or alpha thalassemias, they are not quantitative defects, they are qualitative defects. A point mutation may be there, but the mutations are in the globin gene promoter area, which is a very large area. So the effect of mutations is also huge. So there are different mutations, larger mutations, and they finally lead to either there are no beta chains being produced, or even if they're produced, their expression is less or decreased. And we have, depending upon either the alpha chain is disturbed or beta chain is disturbed, we call it alpha thalassemia or beta thalassemia. There are more than 350 beta thal mutations described in literature till now, and we still are searching for more. You can see this beta 0. When we call it beta 0, that means because of the mutation, the beta chain is not being produced absolutely. There is total absence. While when we mark a plus sign or a 2+ sign, we call it that there is some partial expression of beta chain is there. If it is 2+, it is more than partial expression is there. Now, what happens in erythropoiesis? Till now, we used to know that these are the series of cells which come from the hematopoietic stem cell, which is committed to form a RBC. It undergoes various transformations at various levels, and it finally forms a red blood cell. Now we divide this process of erythropoiesis into 3 basic stages. The first stage is proliferation. The second stage is differentiation, and then there is finally a maturation. After a certain amount of differentiation, our hemoglobin starts forming and coming up. And we need to understand that this all is regulated by TGF-beta ligands. Now, what happens in thalassemia is there is ineffective erythropoiesis. What do we actually mean by ineffective erythropoiesis? It is not that the cells are coming and are not able to reach the blood circulation. They are being formed, but because of the lack of beta unit, there is excess of alpha chains, which causes a cascade of events. We'll just learn in next few slides what cascade of events are taking place. They actually cause the cells to proliferate. Everything is fine till proliferation, but something goes wrong in the differentiation. There is accelerated differentiation, and the cells are unable to mature into the reticulocyte or RBC form. So there is an arrest at this level. This is what we call as a maturation arrest. And after a certain time, when the cell is in the arrested form, it is unable to go further. It undergoes apoptosis. Now, this is what I was trying to tell you about the ineffective erythropoiesis. For years, we have been blaming that beta gene is absent. That is why there is thalassemia. But actually, the beta genes are not the culprit. Beta genes are absent. That is why they leave the alpha globin chains to be unpaired. These free alpha globins are the ones which causes all the cascade of thalassemia syndrome which we see. They are responsible for reactive oxygen species. They form alpha hemichromes, which are, gives rise to different shapes and sizes to RBCs, which we call as anisopoikilocytosis. And since they don't look normal, they undergo hemolysis fast. There is apoptosis and maturation arrest through various pathways and finally leading to anemia. What we need to understand is free alpha chains are unstable. They give rise to reactive oxidant species and cellular precipitates, and they impair the maturation and viability of the RBC precursor cells. So what happens is finally is a terminology is ineffective erythropoiesis, and it gives rise to reduced survival, anemia, increased erythropoietic drive. And since there is anemia, there is extramedullary hematopoiesis, the liver and spleen comes in and they try to come up with their sources of hematopoiesis, leading to organomegaly. And there is chronic anemia, which gives the signals to the GIT that there is anemia, we need to absorb iron more, and which leads to dysregulated iron metabolism. Now, coming to the genotype and phenotype of thalassemia, depending upon the number of chains affected, we can have a typical phenotype in alpha thalassemias. It is very simple. All chains are present, the person is normal. Single chain is absent. This person may not even be picked up in the lab abnormalities. Even the MCV sometimes may be normal or borderline low. If 2 chains are absent, these patients though remain asymptomatic, but they will have a mild microcytic anemia and can be picked up by low MCV in the CBC. If 3 chains are absent, they will be clinically symptomatic and they present like a typical beta thalassemia-like picture: hemolysis, anemia, splenomegaly, bony changes, and iron overload. However, if all the 4 chains are absent, as I discussed in the switchover slide, you need alpha chains to form rest of the hemoglobin. If none of the alpha chains are there, the presentation will be in the embryonic age group only. The fetus may present in the form of hydrops fetalis, and without adequate support may die in utero only. This is what we call it HB Barts, hydrops fetalis or alpha thalassemia major. Coming to beta thalassemia, the phenotypes can be, as we discussed, either it is beta 0 or beta plus. We need to understand that there is absolutely no expression or there is partial expression. When we talk about thalassemia minor, we understand that the one gene is normal and one gene is affected. They present in the form of low MCV, and they will be mild anemia, and in electrophoresis they will be high HbA2. This is how we pick up, but most of the time these tests are done retrospectively when we are able to diagnose a child with Thal major. And the two categories, that is intermediate and major. Major, there is absolutely no expression of the genes, and the child will present in the first 6 months of or first year of life with severe anemia. MCV will be low, and the HbA levels will be very low, with HbF levels will be high because the switchover does not take place. In intermediate, there is some partial expression. The presentation is almost similar to major, but the age is different. The age of presentation is above 1 year. However, solely on the basis of HPLC, you won't be able to determine whether it is a Thal intermediate or major. Previously, there used to be a criteria where they used to tell even if your HbA is somewhere between 50 and 75 or A2 levels are different, then you are able to probably tell that this is intermediate. But now all those criteria have been withdrawn. I would like to highlight a entity known as silent carrier, where your one gene is normal, but the other gene has some partial expression. Now, what happens with this is that many times we do antenatal screening and we see that the mother is normal, or if the mother is Thal minor, we screen the partner and it turns out to be normal, because HB electrophoresis in some partial expression may not be able to pick up high HbA2. These are the mutations which go silent and can suddenly come up in a child, and we are able to see Thal major like presentation in a child. Now, the new thing which has come up is there has been a lot of confusion between thalassemia intermedia and thalassemia major. So all this terminology has been taken away now. Nobody labels the child as thalassemia major, thalassemia intermedia. We call thalassemia, now it is been understood that it is a spectrum of disease. There can be partial expression, there can be absence, there can be total normal. So from normal to total absence, the disease may come up with many manifestations. So all those who were thalassemia major and are requiring transfusion are put into a category which is called as transfusion dependence. TD means transfusion dependence. And all those patients who never required transfusion, like thalassemia minor and most of the thalassemia intermediate patients, they are now kept into a category called as non-transfusion dependent. We need to understand a person who is today non-transfusion dependent may sometime in his life, his or her life, may become transfusion dependent, and the variation may change. So only two categories we need to remember: transfusion dependence and non-transfusion dependence. Now, many a times we see that why this kind of presentation, even if there is a mutation present in the beta gene, why it is that some patients require transfusion throughout life, while some patients are picked up at a later age group of 6 years. I have picked up a child of thalassemia at 13 years. So why it is so? So this has been now understood with the concept of genetic modifiers. It all depends upon what all other mutations or which actual type of mutation a child of thalassemia has inherited, which decides what will be the actual phenotype of the child with thalassemia. So there are factors which worsens the phenotype, and these factors which worsens the phenotype in a heterozygous thalassemia patient. So if the child has one mutation, but the other one mutation but the other chain is normal, still may sometimes present with severe anemia, because a kind of mutation the child has inherited is a dominant kind of mutation, and it has kind of suppressed the other gene. So the presentation, the phenotype will be almost similar to a thalassemia intermediate or major patient. And if there is a alpha gene duplication, The child has inherited normal alpha genes. Along with that, there is duplication. So there are extra alpha chains present. As we discussed, extra alpha chains leads to extra unpairedness of the alpha genes, which will lead to more phenotypic presentation of chronic anemia. They can also present with a exaggerated form of the phenotype. While there are certain factors which decides that this child may not require lifelong transfusion or may not present as the form of thalassemia major. So what are those factors? If the mutation is a milder one and there is partial expression of beta gene or more than partial expression, or there are certain mutations which induce HbF. These are 5 mutations which we have come till now till in literature, which help in formation of HbF. It does not let the gamma globin chains to just disappear. They help to increase in the increased synthesis of gamma globin. Now, how does this increased synthesis of gamma globin helps? As the gamma globin chains are there, the unpaired alpha chains will be able to bind to these gamma chains, and they will increase your HbF level. These mutations include delta beta thalassemia, or what we call as hereditary persistence of fetal hemoglobin, XMN polymorphisms, polymorphisms as BCL11A levels, HBS1L and MYB polymorphisms, and KLF1 mutation. This is important for us to understand because whenever we are deciding about the further therapies, which one of them is induction of HbF, if a child is having any of these mutations, those childs would much benefit from the so-called drugs. And if there is, along with beta thalassemia, inheritance of alpha thalassemia also, this will lead to decrease in the amount of unpaired alpha genes. So this will also partially ameliorate the clinical phenotype of beta thalassemia. So as we just discussed, the severity of mutations, how much alpha thalassemia is co-inherited along with, and the genetic capacity to increase or continued HbF production determines what will be the phenotype of the child. Coming to the pathophysiology, as we have just discussed that all these cascade leads to anemia, and this is not only anemia, it is actually chronic anemia. So whatever happens next is either because of that chronic anemia or because of the interventions we do in the form of RBC transfusions. So extramedullary hematopoiesis, expansion of bone marrow, hepatosplenomegaly, bony diseases, endocrinopathies, heart diseases, liver diseases, all these are part of either chronic anemia or iron overload. What we need to understand also is a child who has chronic anemia, especially a non-transfusion dependent thalassemic child, is vulnerable to vascular diseases and hypercoagulable state also. Their presentation will be very similar to a child who presents with sickle cell anemia. The concept remains the same, that is chronic anemia. They may have thrombosis, leg ulcers, and pulmonary hypertension. Coming to the complication, as we know, transfusion dependent patient undergoes variety of complications, but we also need to understand even non-transfusion dependent patient also undergoes the same complication as a child with sickle cell anemia would undergo. And there are the 3 major target organs which are mainly affected in transfusion dependent thalassemia. These include heart, liver, and endocrine. If we are able to ensure that these 3 organs are taken care of, we ensure the prolonged survival of the child. Along with that, there are few entities which we need to take care of is the transfusion transmitted infections and transfusion reactions, that is alloimmunization. Now, for years, we have been managing transfusion dependent thalassemias in the conventional way. The first and foremost was chronic transfusion program. So what is a chronic transfusion program? It includes that we do not transfuse a child based on hemoglobin. We wait for the hemoglobin to fall and then transfuse the child. No. A chronic transfusion program ensures that since we know the diagnosis and we know that this hemoglobin is going to fall, we do not wait for the hemoglobin to fall. we ensure that a child's pre-transfusion hemoglobin somewhere remains between 9 to 10.5. There have been various regimes under the chronic transfusion program. One is super transfusion, where pre-transfusion hemoglobin is around 12, while hypertransfusion regime is when your pre-transfusion hemoglobin is 10. We follow moderate transfusion program where the pre-transfusion hemoglobin is somewhere between 9 and 10.5. We do not let the hemoglobin fall below 9. This is how we ensure a optimal growth of the child, and we prevent any of the complications related to chronic anemia by following this program. However, this program leads to what we call as iron overload, and the rest of the complication with the child will be because of the iron overload. Initially, there was because of iron overload, the child would not be able to survive beyond the second decade of life. But now, with the good amount of iron chelation therapies available, oral as well, and with the new trials coming up and showing the efficacy of combination of these drugs, they have improved the iron status like anything. And there are better ways to pick up iron overload in the child, especially by MRI T2 star imaging. Now, few patients, they may undergo splenectomy because despite everything, they may have features of hypersplenism, where whatever you transfuse is trapped in the spleen and the spleen size just keeps on increasing and increasing. If there is evidence of hypersplenism, those patients are advised splenectomy with adequate thromboprophylaxis program, because they are very prone to thromboembolic episodes. And as we just discussed, we need to have an annual monitoring of complications, which are mainly endocrine, cardiac, and liver. And the curative treatment option we have is hematopoietic stem cell transplant. 10 years back the line, it was a very, very rare entity. But now with the availability of so many good centers coming up, hematopoietic stem cell transplant in thalassemia is also picking up. I'll just touch this point somewhere later also. What is an ideal blood product? It should be nucleic acid tested PCV ideally. Now this nucleic acid testing is not done at all the centers. It is available only in few higher centers. But that is how we control the transfusion transmitted infections. The blood bank should be issuing a leukodepleted packed RBCs, and this leukodepletion should be done at the level of blood bank pre-storage time. And to ensure that the WBCs do not get transfused in the child, we use WBC filters, but their role is very limited, because whatever cytokines has to be released, they are released at the time of storage only. So by using WBC filters, we are just making 1% of the WBCs not entering into the body. The damage is done if we are not using a leukodepleted packed RBCs. And if we are contemplating transplant, ideally are transfusing whatever unit we are using should be irradiated. However, it is not possible in our setup to use irradiated units, even if the child is contemplating transplant. Coming to the non-transfusion dependent thalassemias, they are offered transfusion on need basis, and they are monitored for any kind of iron overload. We need to understand, even if they are not being transfused blood, their body is still prone to iron overload, and they also need iron overload monitoring, and SOS chelation therapy has to be added. Along with that, a supportive care in form of calcium, vitamin D, and folic acid is added. We may add thromboprophylaxis if splenectomy is being considered. And these are the patients where we have been using a drug which induces HbF, that is hydroxyurea, the same drug which we use in sickle cell disease patients. And they are also offered a final curative option in form of stem cell transplantation. We have come a long way, where dying within first 2 years of life to now survival of almost up till 30 years at very good centers has been taken care of. There is improved survival Along with that, there is a lot of morbidity, but we are trying to take care of that morbidity also. And the deaths are not because of anemia now, the deaths are mainly because of the iron overload complications. Though we have come a long way, there is a lot more to go. Any child who is born a thalassemia comes to my clinic and I explain the parents, this is what it is and this is what you will go through for the rest of his life. It seems like I've been trying to tell them a lifelong punishment. Their life is disturbed. There are so many uncounted, innumerable hospital visits. And as the child grows, the visits doesn't go down. The visits keeps on increasing. The transfusion frequency increases, the monitoring visits increases, the number of tests asked are also increasing. For whole life, they have been fighting for availability of blood. If they have good connections, good donors available, but still it is a task. It is really a task. Any parent going here and there asking for blood. There are few centers which are providing blood, not asking for donors, donor replacement, including our KGP hospital or even this Bhailalameen hospital, where the donors are not asked for. But there are certain times when there is shortage of blood in the blood bank itself. So they are totally dependent upon a product which is being delivered from somewhere outsourced. Transplant option is there, but less than 10% of the patients are able to access the transplant. Thousands of medicines to take, and despite doing all this, they are not living a normal life. There is a chronic pain in bones and joints. They can't do much physical activity without getting very tired. And there are obviously psychosocial issues coming up, especially when they reach the adolescent age group. And this has come from a thalassemia patient mouth only. I wish there was a cure or something to reduce all these medical things so I could have a more normal life. When I treat a child with leukemia, it is something called as Arya-Par. You do a treatment 2 years, after 2 years of follow-up, you are fine and you are cured. That's all. But this thalassemia patient, the morbidity goes on and there is no end to it unless you opt for a curative therapy. So what we are working on it now to see about the unmet demands of the thalassemia patients. In the last decade, there has been a lot of research which has coming up. This has also come up because of the better understanding of the biochemical processes, molecular genetics which have come up, and we are now able to understand and pinpoint what all is causing what. This is the reason that now many drugs which have come up and are now targeting a particular process so that the whole cascade does not take place and the child is able to maintain a hemoglobin at a certain level and becomes transfusion free. As we know that beta globin chain is there and it has genetic defect, and there are leading it to unpaired alpha chain, which impairs the ratio of alpha beta. These alpha chains are causing this cascade. So we came up with a term that we increase the gamma globin. As we learned in the genetic modifier also, we increase the gamma globin so that the unpaired alpha chain binds to these alpha globin and they form what we call as HbF. Any drug which increases the HbF level leads to decreased amount of alpha chains and the whole cascade is prevented. The drugs which are coming up in this category are, I will talk about 3 main: Hydroxyurea, Thalidomide and sirolimus. Now, once there are alpha chains which have come up and they lead to ineffective erythropoiesis. This is the pathology which is being maintained by many parameters, and these GDF, growth differentiation factor 11, is the one main culprit which is responsible for the maturation arrest and apoptosis of the RBCs, and the drug which is targeting this is LUSPATERCEPT. And once there is ineffective erythropoiesis and chronic anemia, we have been able to use a drug which prevents hemolysis or splenomegaly, and the drug which is used at this level is JAK2 inhibitors. And then there is a category of drug which is preventing the iron overload. I'm not sure how much this will be able to solve the problems of the child of thalassemia, as it may prevent iron load or further complication, but still the child would be transfusion dependent even if we take care of the iron overload. So we can divide these novel therapies into two categories: pharmacological options and non-pharmacological options. Amongst the non-pharmacological options, there is gene therapy and gene editing. In the West, especially in US and Italy, a lot of work has been done in gene therapy, and they are coming up with many good trials. But I don't know when this will come to India. And hematopoietic stem cell transplant is getting advanced with lots of help from the government schemes, and some new things are also coming up in stem cell transplant. In the pharmacological options, as I just discussed, we need to address three things. Either we improve iron load by using certain medicines, or we correct the globin chain imbalance by using HbF inducers, or we address the ineffective erythropoiesis by using JAK2 inhibitors or Activin II receptor traps. These are the various drugs which I just narrated in all these three categories, and they are undergoing various trials. And most of them have entered phase 2, and some of them has entered phase 3, and only one drug has been FDA approved, that is LUSPATERCEPT. I'll just go through the important drugs which we have learned and may be in the market soon in India, though they are available in US outside. Addressing the ineffective erythropoiesis, we have two categories: JAK2 inhibitors, that is ruxolitinib, and the second category is Activin II receptor traps, that is LUSPATERCEPT and sotatercept. What does JAK2 inhibitors does? In the up till phase 2 and phase 3 trials, the JAK2 inhibitors, they have understood that we need to use weaker inhibitors. If we use strong inhibitors, they will itself cause anemia. So they are using weak JAK2 inhibitors so that the ineffective erythropoiesis is decreased. The mechanism of action is anti-proliferative and anti-inflammatory, and they mainly inhibit the signaling pathway of erythropoietin. Since as we know that there is anemia, increased amount of erythropoietin is released, which causes the extramedullary hematopoiesis to take place. So if this signaling pathway is chopped, it controls the extramedullary hematopoiesis, and then there will be no splenomegaly. So when there will be no splenomegaly, the size will be decreased, so the blood sequestering in the spleen will also be less. This may decrease the transfusion requirement. The safety profile in thalassemia is under trials, and whatever they have learned till now is that it is just like splenectomy. So if you are, because of the increased size of the spleen, a lot of blood is being sequestered there. This drug may not let the spleen to enlarge in size, and will not have extra requirement of transfusion because of that. So in future, if we are able to use this, maybe it will obliterate the need of splenectomy, but not more than that. The child may still be requiring transfusions. The child will never become transfusion independent solely on the basis of this drug. Coming to a new drug, that is Activin II receptor traps. The two drugs which are in this category is LUSPATERCEPT and sotatercept. LUSPATERCEPT is the one which has been FDA approved in US. It inhibits the erythroid precursors, and all we need to remember is that it decreases ineffective erythropoiesis. By inhibiting the GDF11, it binds to the receptors of it and blocks this GDF11, which is the main culprit behind ineffective erythropoiesis. By doing this, the terminal differentiation of the cells is achieved and the maturation arrest gets corrected. It improves hemoglobin concentration because of that, and this, in short, reduces the transfusion burden in thalassemia. As the hemoglobin gets concentration, as the hemoglobin rises, the transfusion requirement decreases. This got the approval on the basis of the BELIEVE trial, which was a phase 3 randomized double-blind study where all the patients above 18 years were enrolled and were given the 1 mg per kg subcutaneous every 21 days of LUSPATERCEPT was given. And later on crossover was done. And what they could realize was it showed a significant erythroid response. More than 33% patients became almost transfusion independent by the week 13, and more than that after the week 24. This also led to decrease in the iron overload in the body, which was checked in various forms, and it showed statistically significant improvement in the primary endpoint, that was transfusion burden. It also showed significant improvement in the form of secondary endpoints, which was hemoglobin, HbA and HbF levels. It was generally well tolerated and did not show much of any adverse effects, and is a potential new treatment which has been approved by US. But the only thing is, it is approved in the age category of more than 18 years for those patients who are transfusion dependent. The dose as said is 1 mg per kg, may escalate up to 1.25 mg per kg. And the only side effect which we need to watch for is thromboembolic events. Coming to the next category, that is targeting globin chain imbalance. We need to, as I said, that we need to pair the alpha chains. And it works best in patients who have XMN polymorphism. It increases the HbF level and hence improves the hemoglobin levels. There are two drugs in this category. We have been using hydroxyurea for years now, especially in non-transfusion dependent thalassemias. But we have realized that 3 to 4 out of 10 patients, they respond to that this drug. Rest of the patients, though at presentation they are non-transfusion dependent, but somewhere later in life they also become transfusion dependent. It is a largely safe drug, and the only problem being CBC monitoring to check for cytopenias. The dose is around 10 to 20 mg per kg. The new drug which is coming up in thalassemia is Thalidomide. It is also one of the drugs which improves the HbF level in a thalassemia patient. We know it as a controversial drug because it was introduced in the market long back in 1950s as a drug which treated insomnias, URTIs, and morning sickness like a wonder drug. But after 10 years, this drug was banned because the children started getting birth defects. And then somewhere in early 2000s, it was reintroduced for the treatment of leprosy. And the irony is that because of this anti-angiogenic properties, the drug was banned because it caused anti-angiogenesis in the fetus, and there was phocomelia-like presentation. And now its anti-angiogenic properties are being explored for its uses and is now being currently prescribed for multiple myelomas, myelofibrosis, and certain malignancies. This was the first case report somewhere in 2008, wherein a child who was 21 years old had been on chronic transfusion since the child was 5 months of age and has been receiving chronic transfusion till the child got 21 years, and she developed large alloimmunization, could not tolerate any blood product. Every time she would come back with a hemoglobin of 2 or 3, and she also underwent splenectomy because of that, but there was no respite. In this girl, the drug Thalidomide was tried, and she became transfusion independent in 3 months. This was the first case report to demonstrate the efficacy of Thalidomide in a thalassemia patients. Multiple pilot studies, especially in the last 5 to 6 years, have come up, and all of them has concluded that 6 out of 10 patients may become transfusion independent because of by the use of Thalidomide. However, there was not a single good study which you can tell that yes, there is no long-term data available. This is the meta-analysis of certain pilot studies, one randomized controlled trial, which was published in the just 3 months back only, January 22. This meta-analysis included these 12 studies taken up from multiple centers, wherein one randomized control trial was only available. Rest of them were single pilot studies, and all of them had used thalassemia in transfusion-dependent as well as non-transfusion-dependent thalassemias. The age group has been variable, somewhere between 3 to adulthood, and the dose was also variable, 2 to 10 mg per kg, and all of them had shown a statistically significant increase in HbF and hemoglobin. The spleen size regressed and ferritin levels decreased. And the common adverse effects seen were sedation, constipation, rashes, proteinuria, thromboembolic event, and few case reports of peripheral neuropathy were also reported. The current status is that a long-term safety profile needs assessment. Large randomized control trials are needed to know, because all of these studies have a very short follow-up regarding the adverse effects. None of them followed up the patients, or at least data was not provided what happened after 1 year. So larger randomized control trials are needed, and this may emerge as a promising drug once long-term safety data is available. Coming to hematopoietic stem cell transplant, as we know, it is a curative option, but it is favorable to only those patients who are less than 12 years of age. Above 12 years, there are lots of incidences of failure or GVHDs. Ideal candidate is a well-transfused, well-chelated, and no liver fibrosis. However, as we know, it is not feasible to all because of the unavailability of donors, the cost, and limited access. And now the government schemes are coming up, especially in various centers where under Ma Yojana or Ayushman Yojana schemes, children are able to access this, but again, the donors still remained an issue. So now they have come up with two new concepts in HSCT, that is haploid transplant, wherein 50% of the match is available in the of the parent. They can be taken up as a donor. However, this again becomes a costly affair, and the efficacy or the results of the haploid transplant is still not as good as compared to a 100% sibling match. Now, I had one patient who had thalassemia intermedia, was non-transfusion dependent thalassemia, came up with short stature, a huge spleen, and became transfusion dependent because of its growth failure. Their parents were too motivated to undergo hematopoietic stem cell transplant, but there was no donor, and they did not want to take risk of haploid transplantation. What they did was they underwent IVF conception. And through that IVF conception, there was pre-implantation genetic testing was done. Pre-implantation genetic testing removed all the thalassemia disease embryos, and before implantation only HLA matching was done. And those who matched fully with the patient, only those embryos were transplanted, implanted into the mother's womb, and the mother was able to a healthy baby who was not thalassemic and a full HLA match for the child. Now they are ready to transplant and formalities. Coming to the conclusion, we know that thalassemia disease is a chronic disease with a lot of morbidity. It is a team approach which requires lots of specialists to pip in. Chronic transfusion and iron chelation, which we have been following for more than 4 decades now, it is actually a stopgap arrangement. And HSCT is a definitive cure, but only less than 10% has this option. A definitive, simpler pharmacological treatment is the need of the hour. Thank you.
Thank you, Dr. Urvinder.
Yes, ma'am.
It was really very good talk, and we came to know so many new things in last few years. Now, are there any questions from the audience?
Somebody has written in the chat box, what is the practical way to deal with the child who has low MCV with 30 to 40% iron deficiency in India? Do you give iron 4 to 6 mg per kg and repeat CBC in 1 to 2 months? I am from USA and always unsure of what to do here in India when I treat children in remote areas without access to hemoglobin electrophoresis. See, if a child is having thalassemia, we have to look at the whole clinical picture of the child. A child with thalassemia will have organomegaly, hepatosplenomegaly will be there. While iron deficiency anemia, there would be no hepatosplenomegaly. They will be only in very severe iron deficiency anemias. Less than 5% of the patient may have hepatosplenomegaly. The best thing is normally we ask for when we check the MCV, it is just a guide to tell you MCV somewhere between 55 and 75 is more suggestive of thalassemia minor or thalassemia major, while a MCV which has gone below 55, somewhere around 50, 48, these MCVs are surely suggestive of iron deficiency anemias. The second thing is, we don't ask for iron studies nowadays, we ask for retic count. In a retic count, there is an entity known as CHR, that is reticulated hemoglobin content. Previously, we used to ask for ferritin, but thalassemia being a chronic disorder, where chronic inflammation is also going on, it is not possible to differentiate whether this child has underlying iron deficiency or not. But CHR is independent of inflammatory state. If there is iron deficiency, CHR will be low, and it is a gold standard test to pick up iron deficiency. If it is low, you treat with iron, even if it is thalassemia minor. This problem occurs especially in thalassemia minor patients. When we see a hemoglobin of around 8.5 or 9, and we see HPLC report there that yes, this is thalassemia minor, we also need to check whether this child is iron deficient or not. So we ask for CHR levels. If CHR levels are low, we treat that child with iron, even if it is thalassemia minor patient.
Any other question? Would you like to say something about prevention? Very basic thing for
Madam, prevention has to be done at the level of gynecologist.
That's right.
Yeah, the prevention has to come from gynecologists. I guess we have had lot of treatment options, discussions is being there, but now we need to actually go and meet all gynecologists and tell them to get HPLC done for all the patients. If we are doing CBC, TSH, HIV, HBS, AG, this all things are being done. HPLC should also be a part of their routine testing in all expecting mothers. You won't believe that I feel very sad when a mother who has undergone IVF and comes up with the twins, both of them suffering from thalassemia or sickle cell. I can't tell you how bad I feel. It should be a part of every antenatal screening that a HPLC should be asked for.
Right. Okay. No more questions? Thank you very much again, Dr.
Thank you, ma'am.
એનિમિયામાં લગભગ બધા કરાવે છે પણ હવે કરાવે છે.
Okay. So we conclude the meeting here.
Thank you, ma'am.
Thank you.